Hello, everybody, for the second day of the TANUVAS Global Webinar Series on Large Animal Sciences. So today we have a wonderful session on the topic that is production diseases in cattle. The speaker of today's topic is a well-renowned person, Dr. Angel ABUELO. He is from Michigan State University, USA. So on behalf of the Tamil Nadu Veterinary and Animal Sciences University and the Directorate of Clinics, and on behalf of the Veterinary Clinical Complex, Veterinary College and Research Institute, Namakkal, I wholeheartedly welcome Dr. Angel ABUELO and the Director of Clinics and the Deans of the constituent colleges and all the participants, organizing team, and over to Dr. Arnaman Asanpauser for introduction of the speaker.
Thank you, sir. Good evening, one and all. I'm happy to introduce Dr. Angel ABUELO. Dr. Angel ABUELO obtained his veterinary and PhD degrees from University of Santiago de Compostela of Spain and Masters in Veterinary Education from the Royal Veterinary College, UK. He is a diplomate of American Board of Veterinary Practitioners, the European College of Bovine Health Management, and an associate diplomate of the American College of Veterinary Internal Medicine. Dr. ABUELO is a registered specialist in cattle health and management in America, Europe, United Kingdom, and Australasia. After graduation, he joined the faculty at Charles Sturt University in Australia, where he was responsible for the dairy production medicine services. Since December 2017, Angel is Assistant Professor of Cattle Health and Wellbeing at Michigan State University College of Veterinary Medicine. Angel's research focuses on the interplay between nutrition, metabolism, and immune function in dairy cows and calves. At MSU, he maintains federally funded research and extension programs, contributes to the clinical training of final year veterinary students, and provides continuing education to the veterinarians. Dr. ABUELO has authored more than 30 scientific articles and case reports in international journals and is editor for the journal Nature Scientific Reports and PLOS ONE, and editorial board member of several other journals, and a frequent peer reviewer. Thank you, sir. With this, I hand over the mic to Dr. Angel. Over to Angel. Thank you, sir.
All right. Thank you very much, and thank you for having me today. Okay, I think that I'm sharing the wrong screen now. Let me try again. Okay. Let me. Now you pro. Can you see the screen now?
Yes, sir.
Perfect. Thank you. So yeah, I was saying, thank you very much for having me today. It's a pleasure to be with you. And yeah, so what I'm going to talk about today, it's about really updates on particularly diagnosis and treatment of production-related metabolic diseases of cattle, which are really like the main ones, or in particular in dairy, ketosis, milk fever, and hypomagnesemia or Grass's staggers. Obviously, I really cannot take all the credit for all this work. This is kind of like Emma said, for like an article that two colleagues from Cornell and I wrote last year, or well, 2 years ago now, that is published in Practice, where we really just review these concepts. So this is really what I'm going to talk about, and hopefully we can have like a nice discussion at the end. So why do we call it, or why do we design them as production-related metabolic diseases? It's usually because they are associated with the fact that the production's peak is beyond the capacity of the animal reserves to sustain a particular metabolic demand, whether it's energy in the case of ketosis, calcium for milk fever, or magnesium for hypomagnesemia. And those kind of like increases in metabolic demands usually take place after calving, because the demands for milk production overwhelm all those kind of like physiological regulatory mechanisms. And treatment strategies have been available for those diseases for many years. What is like surprising is that sometimes like the evidence that there is to support some of those treatment plans is very scarce or limited in some cases. So we have been doing things for like many years that actually when you start looking at the evidence behind it, there is sometimes none. And yeah, those treatment strategies really like the question that is still is there is like what is like the optimal treatment that or treatment strategy for like the recovery of the animals and then making sure that they return to their full productivity. So again, as I mentioned, purpose for today is really to review what we know, our current evidence for like the treatment of ketosis, milk fever, and Grass's staggers or hypomagnesemia. So let's start with the first one. And really, we've been calling it ketosis for I don't know how many years. More correctly speaking, really, it's hyperketonemia. This is really what we are measuring. We are measuring just like increase in the concentration of ketone bodies in blood, which is like the definition of hyperketonemia. So how this happen? Just need to again really remember that ruminants do not absorb copious amounts of glucose from their diet. So the glucose or like the starch that might be available in the diet through like dietary polysaccharides gets metabolized by the bacteria in the rumen to just kind of like generate volatile fatty acids, which are really what they are absorbed by the rumen, and then is the liver's work to convert that into glucose for energy. And remember that particularly in early lactation, most of that glucose that is available in the bloodstream will be used by the mammary gland to synthesize lactose for milk production, because that step gets prioritized in the metabolism of the animals at that stage. So most of the glucose that gets generated for like, or de novo synthesis of glucose during early lactation really gets generated or it gets used by the mammary gland. So that means that the other tissues need to work primarily with other fuels. Some of those are like the ketone bodies that we already know. Like the main three ketone bodies for dairy cows are acetone, acetoacetate, and beta-hydroxybutyrate. And those really get generated when the animals enters a period of energy deficit, because what it can intake is not, or the energy that it can intake by the diet is not sufficient to support their metabolic demands for lactation. So they start like mobilizing fat and muscle to come up with that extra energy and protein. So just going through like a quick overview of how this happens, really, when we have like our adipose tissue or fat, where we have really, or like the cows and we as well, have like triglycerides, those under periods of energy deficit, they get lipolyzed. So we have like, so in the bloodstream, we get like the release of non-esterified fatty acids or NEFAs and glycerol that then go into the liver, and in the hepatocytes get esterified again. So now we have like esterified fatty acids that usually will undergo beta oxidation, get to the mitochondria, and get converted into acetyl-CoA and get into the Krebs or TCA cycle and generate glucose for de novo synthesis. As you know, for this acetyl-CoA to enter the Krebs cycle, we need some precursors. So it gets to a point where like all that cycle, there is not sufficient metabolized there for like more acetyl-CoA to go in. So this step kind of like gets blocked, and in a less efficient manner, so that acetyl-CoA gets metabolized into ketone bodies that then can get exported and used for oxidation in peripheral tissues. So other tissues would use ketone bodies as a source of energy. An added problem here is that sometimes like the rate at which like triglycerides or like lipolysis occurs and triglycerides gets converted into NEFA exceeds the metabolizing capacity of the liver to generate ketone bodies, which it's not a very efficient pathway as mentioned before. So what happens there is that we end up with a lot of like esterified fatty acids inside the hepatocytes of the liver. So then those can follow different pathways. One is like, well, they get combined with glycerol again and form triglycerides. So you can see how much energy we lost or the animal loses in these steps where we have like triglycerides. They convert it into several things to then go back to triglycerides. And those can be exported through lipoproteins and used in other tissues, such as like the mammary gland that would use those lipoproteins to synthesize milk fat. However, ruminants, and particularly cattle, have a very low export capacity of lipoproteins. So those triglycerides get a storage in the liver waiting to be transported, and that's how fatty liver gets generated. So this is kind of like in a nutshell, a quick overview of all like the energy metabolism that happens there. Another important thing to remember with like ketone bodies, and particularly beta-hydroxybutyrate, is that, as we saw before, one of the volatile fatty acids is butyric acid, and that one can be converted directly in the rumen epithelium to beta-hydroxybutyrate. So even if it might be that a cow is ketotic or has hyperketonemia, not because of everything that's happening in the metabolism, but, for example, if it's eating poorly ensiled forages and things like that that are really rich on butyric acid, we can be like feeding the cows butyric acid so that it's just like as if we were giving them beta-hydroxybutyrate. And I had like some cases where there was like, when you see like ketosis not in early lactation animals, most of the times it's associated with this. So again, remember that when we measure beta-hydroxybutyrate in blood, it's both the amount that gets synthesized by the animal and the amount that can be derived from the diet. Okay, so as I mentioned before, like ketone bodies are an alternative energy source, and a slight increase during times of nutrient deficit, such as in early lactation, it's physiological. So yeah, cows are going to undergo right after calving a period of energy deficit. So an increase in the production of ketone bodies during that time is expected. The problem occurs when these increases are above normal, or what we would consider normal for the stage of lactation. And that's what we call like hyperketonemia or ketosis. It's hyperketonemia, really, again, this is like really dependent on which cutoff point we want to use. We commonly use beta-hydroxybutyrate as our gold standard measurement because it's like the more stable one, and it's like the one that has like, there is like more evidence linking concentrations of beta-hydroxybutyrate with subsequent disease risk. So we usually consider that as 1.2 millimolar or millimoles per liter, or 1.4, depending, again, there is a trade-off between the sensitivity and specificity depending on the cutoff point that you use. And then we can classify hyperketonemia into either what we usually call like subclinical, which is, okay, an increase in ketone bodies above our cutoff point, 1.2 or 1.4, without clinical signs. So it's something that if we don't test the cow for it, we don't know that the cow has subclinical, that has hyperketonemia. And then like the clinical hyperketonemia is like, well, the combination of increased ketone bodies in blood and then clinical signs of ketosis or hyperketonemia. Traditionally, there was also like a classification between type 1 and type 2 ketosis that kind of like tried to mimic what the classification that it's used in humans for type 2 and type 1 diabetes. However, this is now considered a somewhat old paradigm since research in the recent years have really fully elucidated that the metabolic picture of cows in early lactation has nothing to do with the clinical and metabolic picture of humans suffering from diabetes. So really this type 1 and type 2 is kind of like no longer of much relevance. So again, epidemiology of the disease. So it's obviously like most prevalent among high-producing early lactation dairy cattle. We've already went through like the early lactation, and obviously the higher the milk yield, the higher the metabolic demands. So the more energy that the cow needs. Dr. McCart back in 2015, and this again for like a average US dairy herd estimated the cost of hyperketonemia. So just having, and this is just like the subclinical part. So having a cow with in early lactation with increased ketone bodies costs, $289 US, which according to the conversion that I did yesterday, it's about like 21,000 rupees per case, which might not seem very much, but then when we look at the prevalence, and again, this is a disease that varies a lot among herds because a lot of it has to do with like the nutrition management, etc. But as you can see, is that okay? Like in different countries, I couldn't really find a prevalence indicator for India, so I don't really know. I'll be really interested to know if you have that data. But for example, in New Zealand, there were like the studies that showed like the average like herd prevalence was about like 30-ish%. In Northeast US is between like 40 and 60, and in Europe it's about like 21-22%. So like something between like 20 and 30%. But the problem is that this is really its prevalence. When we think about like incidence, the incidence might be like double the prevalence because hyperketonemia is really a disease of short duration. So it's been shown that the elevated ketone bodies in blood will only like remain like elevated for about up to like 5 days. So it is possible that by the time that we go, even if we monitor regularly cows, if we are just monitoring them once a week, it is possible that cows that get tested and test negative because they are already beyond the point where the ketone bodies are elevated. So that's why like the incidence is always going to be higher than the prevalence. And really to be like measuring the incidence of ketosis in a herd, we would need to be like testing cows at risk bi-weekly, which is very intensive, and no one does it. It's unless it's for like research purposes, of course. So on practical terms, we usually just test for prevalence and then just assume that the incidence is going to be higher. But if you can think that we can even like be almost like double, that just means that we are talking about like 27, 30%, 22, 40 to 60, like that means that's like about like more than half of the cows in a herd will experience hyperketonemia. So multiply that times the cost per case, and that's a lot of money that gets lost. And another interesting part about like this calculation is that most of these costs are due to what it's called like the hidden costs. So costs that the producer will not regularly see, such as like the decrease in milk production that is associated with hyperketonemia. So it can have a significant economical impact on dairy herds. Apart from that, again, hyperketonemia, usually the peak of incidence is during like that first week after calving, just because that's when we have like that sudden increase in metabolic demands. And it's considered where it's like a gateway disease. So apart from like everything that we know about ketonemia, we know that cows that experience hyperketonemia during early lactation are at a higher risk of developing other diseases. And here you have like some of like the estimate. So a cow that has a hyperketonemia is going to be like 3 times more likely to have a displaced abomasum, 5 times more likely to have clinical ketosis, 2 times more likely to be lame, 1.4 more times likely to increase somatic cell counts or mastitis, and also like all like the losses associated with milk yield and reproduction efficiency. It's also been shown that obviously cows can have like ketosis that are in the first and second weeks. So the greater risk of adverse events or like other diseases is greater if cows are ketotic in the first week of lactation versus in other weeks. So it's worse when they have ketosis in the first week of lactation than if they have it, let's say, in the second or third week. And there's also like a lower risk of hyperketonemia in primiparous compared to multiparous cows. Obviously, one of like the main drivers for that is potentially that primiparous cows do not usually produce as much milk as multiparous cows, so their nutrient demands are lower at that stage. Clinical signs of hyperketonemia, again, unless we are talking about like really severe ketosis, the diagnosis by clinical signs alone is usually difficult because the signs are very vague and vary a lot between animals. So sometimes when you say like, oh, this is clinical ketosis, you cannot really correlate clinical signs with the degree of hyperketonemia. Also, the majority of hyperketonemic cows are subclinically affected, so they do not exhibit clinical signs. And as I mentioned before, I have like cases where cows where like we had like very high beta hydroxybutyrates readings do not show clinical signs. Sometimes would you even like think if the machine is properly calibrated, but because the cow appears normal, but she does have that. So, and those clinical signs, even though they're, as you can see, they're really vague because they're not really pathognomonic or specific. So we have like, okay, decreased intake, a dietary preference for roughage or like hay over grain, a decreased milk production. Sometimes they would have obtundation or a decreased mentation status. They would have like Fearman scant feces. So you can come up with several other potential diseases that would have also those clinical signs. Unless then, when it's called like when it progresses, like so, these are like kind of like the clinical signs in the first stages of the clinical disease, and then it usually progresses to like nervous ketosis, in which like cows would be like aggressive, will show ataxia or difficulty moving, will like salivate, and interesting, like they also start to like bite and chew on hard objects. And I have like a video here that hopefully I can make work, or you can see like this, like a cow with nervous ketosis. What she's just doing is really like trying to bite and lick the metal part of the chute. So that kind of like behavior is suggestive of ketosis. To diagnose ketosis, again, since we cannot really rely most of the times on clinical signs, we need to rely on testing for ketone bodies in body fluids. Luckily, we have like different methods that we can measure ketone bodies in milk, blood, or urine. And we have like both semi-quantitative or quantitative tests. So for example, like the semi-quantitative are like the either urine or milk strips that you have here, so where we just kind of like dip the stick into the fluid, and then on a color scale we can have an indication or what the concentration is. Or it can be like fully quantitative, such as like these ketone meters for measuring like beta hydroxybutyrate in blood, that will actually give us an exact numeric value. Also important to mention that the concentration of ketones varies throughout like the different fluids. So it's like they're like usually more concentrated in urine and least in milk. So kind of like the cutoff points for each of those fluids are going to change. And as I was mentioning before, there we also have like different cutoff points for like those different like ketone bodies. And again, we have like either handheld devices or reagent strips. Those are like a few of the initial ones that like ketometers that were validated for use in cattle. And that's something that I want to really stress, is that just use devices that have been validated and there's evidence that they work in cattle. Those devices are not developed or were not intentionally developed to test ketone bodies in cows. They were developed to test ketone bodies in humans suffering from diabetes. And I don't know why, but some of them do not measure ketone bodies well in blood of cows. We tested several, and some of them just, you can see like very spurious results when they have not been validated. Again, these tables from an article that we wrote back in 2016, so it's already been old. They have like other devices that have been validated, but like the take-home message is, let's just do not buy one and just start testing. Just make sure there is evidence that supports that they can be tested or used in cows. And as I mentioned before, I mean, you have like different cutoff points for like, and those are it's always like a trade-off between the sensitivity and the specificity of the test, and whether you want to like prioritize ruling out or ruling in the disease. Another important thing is to actually know which ketone bodies each test is measuring. So all the handheld devices measure beta hydroxybutyrate. That, again, as I mentioned, that is usually our kind of like reference ketone body. But for example, the urine reagent, like the urine strips, measure primarily acetoacetate and a little bit of acetone as well. Obviously, like the cost per reaction is a little bit higher in the handheld devices than what you can see on a strip. But it also provides more useful information since it's actually giving you an exact value. So that's for like really identifying cows at the individual level. What happens is that most of cows are usually handled as part of a group. So we need to care about the herd level diagnosis. So really, again, there's always going to be like some variation among cows. So what important, and some cows would have hyperketonemia right after calving. The problem is like whether we have a problem in the herd or not is whether that prevalence of hyperketonemia is above what we had determined to be our alarm level for the herd. And we need to always take into account that our testing and other things are going to affect that herd level diagnosis. So if we use like a test that has a low sensitivity, that's going to negatively affect our ability to correctly classify the herd as, does this herd have a problem, yes or no? So that's why we usually just go, even though it's like more expensive, to the handheld devices for like a more like herd level diagnosis. If the prevalence of the herd is low, it's also going to impact that. It's going to be like harder to find those positive cows. And if we use a small sample size to get an estimate of the prevalence of the herd. So those things are things that need to be considered when designing a metabolic health monitoring program for herds. Moving on to treatments now, we have like primarily like the treatment options for hyperketonemia can get classified into three main categories. One is like the IV glucose, which is what we have been doing for ages. Then the oral gluconeogenic precursors, which is like propylene glycol, and then other supportive treatments such as vitamins, choline, or glucocorticoids. And we are just going to go and check like the evidence supporting those different treatments, and we are going to kind of like change the order and go for like the one and go in level of supporting evidence starting for the strongest. So that means that we need to start with oral propylene glycol. So this is like the treatment option that has like the strongest scientific evidence that it works for both the prevention and treatment of hyperketonemia. And those studies are like randomized, properly designed, randomized controlled trials. And the conclusions of those studies really says like giving cows, as you can see here in this picture, where we are given propylene glycol, or the student is given a propylene glycol with a gun, that a 300 milliliter bolus of propylene glycol orally once a day for 3 to 5 days shortens the time to recover and reduces the negative outcomes associated with hyperketonemia, such as decreased milk production, lower reproductive efficiency, etc. So it helps the cows recover fast and also to correct that hyperketonemia. How does propylene glycol work? So it actually works through two different levels to support gluconeogenesis. So when we feed like propylene glycol to the cow, that propylene glycol, part of it gets metabolized and broken down to propionate, which is a volatile fatty acid, or BFA, that then kind of like gets absorbed and gets used to support gluconeogenesis. And another one, kind of like propylene glycol, also gets absorbed and gets into the TCA cycle or the Krebs cycle and restores those kind of like metabolites that we were seeing before, so that the acetyl-CoA that is coming from the fat can enter the TCA cycle. And I have it like here more clear in this picture. So here's where we have like our kind of like fat metabolization that we saw before, and then like our acetyl-CoA. So propylene glycol, again, gets metabolized and in part supports oxaloacetate, and that oxaloacetate can either get combined with acetyl-CoA and then that can restart the TCA cycle, or also that oxaloacetate can also directly be used for gluconeogenesis. And again, that also like that propylene glycol, the propionic acid, when it gets metabolized, can also enter at another level at the TCA cycle and restoring the reserves or the different intermediate metabolites of the TCA cycle. So we are kind of like restoring, it helps to restore both gluconeogenesis and like the use of, or the metabolism of fat. So we then like that acetyl-CoA will preferentially get into the TCA cycle instead of generating ketone bodies. The second treatment option is IV glucose or dextrose. And again, this was like really interesting because this is like something that has been reported forever, that's like the treatment of choice. And it actually, like, when you think about it from a biological point of view, it does make sense. It's like, well, the cows, the issue that they have is that they don't have sufficient energy, so let's just provide them with energy sources directly. And that was partly driven because there was an association between lower blood glucose and ketosis in cows. However, when you look at the literature, this actually, like this treatment, there was like literally like no randomized control trial, not properly designed study to support the efficacy of the study. Well, until recently, this actually has been recently tested. And it was like there was like a couple of studies that were published in Journal of Dairy Science 2017 and 2020 that actually showed that IV glucose alone performed worse than propylene glycol alone in terms of restoring like normal ketonemia in cows. Because, and the combination of propylene glycol and glucose, so given both of them, reduce beta-hydroxybutyrate to a greater extent in hyperketonemia cows. However, that addition of glucose did not influence those other, like, what, let's put it this way, what the producer cares about. So it did not reduce the risk of disease. It did not improve milk yield or anything. So it's really like, so just giving IV glucose over propylene glycol, it doesn't seem to have an added benefit in like the recovery of the animal. And one of like the main problems with that as well, or additional problems with how we do it, is that, okay, in most situations, a continuous infusion of glucose at low concentrations is not practical in the field. And it also actually would further decrease dry matter intake, because if the cows are already like receiving glucose, then they are not going to eat. So that's even going to make things worse. So that's why that continuous drip is usually not recommended. And when we do it on farms, again, like as here Matt, a vet student, is doing while speaking with the farmer, is administer via a bolus. So that means that we get like usually like 50% dextrose solution, and we administer a lot at once. So the concern with that is that, well, really, when we increase glycemia that much, we are really exceeding the renal threshold. So we have like suddenly a lot of glucose in the blood. So about half of that glucose is believed to actually just be lost in the urine. Because once we get above like that renal threshold, the cow will just pee the glucose out. And with that kind of like increase on renal function, there were like concerns that they would also like excrete other like minerals and things like that are very important for the metabolism and homeostasis of the cows at that stage. However, this like Mann et al. 2017 study showed that given up to 250 grams of glucose, which is like a half a liter bottle of a 50% solution, is safe in terms of those kind of like maintaining the blood concentrations of those minerals. So with all that put together, really our suggestion is just to limit IV glucose to cows that actually have either clinical signs of disease, or like those kind of like nervous ketosis that need to have like a fast restore, or like they need glucose right away, or those that have like, again, ketone body concentrations really high, such as more than 3 micromolar beta-hydroxybutyrate blood concentrations. Other treatments that have been, again, used for many years are the use of glucocorticoids or dexamethasone to treat ketosis. Again, something that it made sense in principle biologically, because, that increase in glucocorticoids is going to change the glucose use in the cow, and it's meant to the cow doesn't have glucose, and we give glucocorticoids, we are producing that hyperglycemia. So then, hey, there's the cow that now has glucose available and also blocks the insulin effect. So it's more like about like changing the availability of the glucose in the cow. However, recent trials actually show that the use of dexamethasone is a little bit controversial. So, while a small study in a small number of cows showed that the combination of propylene glycol and dexamethasone increased glucose and insulin concentrations and decreased beta-hydroxybutyrate, which was like a positive finding. Other better designed studies with larger sample size showed that the combination of dexamethasone and propylene glycol actually reduce the pregnancy risk at first insemination, so reduce reproductive efficiency, and increase the duration of ketosis, which is something like bad. And also a single injection of, again, this was another glucocorticoid like isoflupredone, between 3 and 5 days postpartum in hyperketonemic cows, is going to increase the risk for ketosis in both healthy and ketotic calves. So it's something really bad. So based on these findings and the immunosuppressive effects that glucocorticoids can have in cows, glucocorticoids right now are not recommended as a general approach to ketosis treatment, because really it's more like negative than benefit that you can get out of it. Other supportive treatments that have been suggested and things like that, such as, for example, the use of vitamin B12 or phosphorus. Again, while it makes sense biologically, such as vitamin B12 has a role and supports gluconeogenesis, and phosphorus is required at many of those stages of the nucleoneogenic pathway. So it's meant to meant to support the metabolism. There's actually not sufficient data to actually show that those treatments are actually of any benefit. So again, obviously nowadays we focus more on prevention than on treatment. So we always try to go upstream rather than downstream and try to prevent the problems from happening. So again, to prevent hyperketonemia, we really need to focus on the start of the dry period and then follow adequate transition cow management protocols. So we need to, one of the key features is to prevent the overconditioning or fat cows in during late pregnancy and dry period. And that's a lot of the times is associated with the reproductive management, because if we don't get cows pregnant early enough in their lactations, then they are going to have extended lactation, so they're going to gain weight, and by the time that then they get dried off, they are overweight, and those cows are at a higher risk of hyperketonemia. During the dry period, the nutrition is really important, and particularly what we call the dietary plane of energy. So the energy intake should be designed to meet but not exceed greatly their requirements. Because overfeeding dry cows, again, predispose them to metabolic diseases. And on the other hand, as mentioned before, they are going to gain weight, and then when they calve, they are going to lose even more weight. And on the other hand, we also need to avoid restricting energy prepartum, because then the cows are going to enter that energy deficit period earlier, and that's going to make them that they are going to be mobilizing fat when the increase in metabolic demands happened, so that then they will like mobilize even more fat. So that's even going to get worse. So really how we approach that so we can actually like have the adequate amount of energy in the diet is just like diluting or limiting the energy density via including forages that are low in starch and high in fiber. So primarily what we do is like dilute their rations with high quality straw. So they still have like that rumen feel, but the amount of energy that they intake is controlled. Obviously, like cow comfort and the facilities also play a huge role because everything is intertwined and also going to affect nutrition. So they need to, or cows in herds need to, again, we have to provide sufficient space so that we can avoid competition at the feed bank so all cows can eat. We try to need to mobilize what is called like social stress and trying to minimize moving cows around from one pen to the other and try to move groups together as much as possible. And obviously another important feature during this time is heat abatement because heat stress has had very important role and has been shown to negatively impact not only the cow, but also the calf or the fetus that is inside that cow. And again, other things that can help like prevent hyperketonemia, and there's started to be like some evidence about that, is like the inclusion in the diet of dry cows of like supplements such as choline, B vitamins, and monensin. I'll say that here in the US because in Europe, monensin is no longer licensed. Not really sure what the situation is in India with that. Okay, so moving on to the second of the diseases that we are going to talk about today, we are going to talk about hypocalcemia, of which like milk fever is usually what we call like the clinical presentation. Even though cows never had a fever associated with hypocalcemia, so actually if they have something, usually they have like a decreased rectal temperature, so it's just interesting how that name came through. So hypocalcemia, again, like was first described in 1793, so a long time ago, and it's associated with a large deficit in calcium. And this is associated with, the sudden and very dramatic increase in the demands for calcium that are needed to support colostrum and milk. And plus the added fact that cows usually eat less around calving, so they can ingest less calcium. So that large calcium deficit takes days to rectify. If you look at how all the calcium stores in a cow, you can see that most of it is stored in the bone. So that means that if a cow needs to mobilize calcium, it needs to mobilize it from the bone because of the amount of blood the amount that is available in blood or in other fluids. It's ridiculous compared to the amount that is in blood. And it does not even support the production of a couple of liters of colostrum. So to mobilize that, then that takes time to mobilize that calcium from the blood. So that's one of the things that when we talk about like prevention, what we try to do is try to get cows to mobilize calcium before calving so that they are already ready and mobilizing calcium, because that kind of all those mechanisms to mobilize calcium take a lot of time to activate. So if the cows are already mobilizing calcium when it comes to prevention, then those amounts increase, they're going to be ready and they're going to mobilize that. Other things that are really needed to kind of like correct that hypocalcemia is the blood pH. So here what we have like the receptor for the parathyroid hormone that, as you can see, plays like a central role in regulating both like the bone resorption of calcium, the reabsorption of calcium by the kidneys, and also like the absorption of calcium by the intestine. So if this doesn't work, none of this happens, and then we don't have a correction of calcium concentrations. So for that, like PTH or parathyroid hormone to work, we need two things. One is like we need like a slightly like or normal or slightly acidotic pH, because under alkalotic conditions, the receptor for PTH is kind of like its shape transforms, so there is no binding between PTH and the receptor, as you can compare to here. And also magnesium is also needed as a cofactor for that to work. So if cows have low magnesium concentrations in their diet or in their, and as a consequence of that in their blood, then they are going to not be able to control calcemia. And the same thing with if the blood pH is high. When we talk about epidemiology of hypocalcemia, when we think about just milk fever or like the clinical presentation, it's usually considered normal or expected to have a somewhat like an incidence risk between 2 and 5%, particularly in older cows. Again, it's another disease that varies among farms, and it can go from like, there are like reports of like farms that have nothing to cows that have like 83% sometimes when they're going through like an issue. Again, we're going to see that this is a lot like has to do with diet again. And yes, and obviously cows that are at a greater risk are like greater parity cows. So as cows get old, they are at a greater risk for milk fever. And also like those Channel Island breeds, such as like the Jersey and Guernsey and everything, compared to Holsteins, for example, at a higher risk for like milk fever. These cows have a higher time trying to regulate calcium. And the same as it happens with hyperketonemia, we also have like subclinical form of the disease, in which, again, if we don't test for it, because there are no clinical signs, we don't know that we are having it on it. And that happens in about like the prevalence of that, it's about 50% of fresh cows. And here, like in this study, was shown that obviously when you think about it, like after like the second lactation, the values of prevalence of subclinical disease go or vary between like 40 and 50%. And usually, as I mentioned before here, like primiparous cows are at a lower risk for milk fever, and usually we don't see milk fever in heifers when they calve. But they do still experience subclinical hypocalcemia. So you see here, okay, like the prevalence of milk fever in first lactation animals is only 1%, which is like way lower than the other ones. And here, yes, subclinical is still lower, but it's still like a quarter of the heifers that have subclinical milk fever. So yeah, even though it's like less of a problem, I would think that the magnitude is still considered too important. And another feature to consider is that when this study was done, the cutoff point that was like usually used to define subclinical hypocalcemia was 2 millimoles per liter. Right now, that cutoff point is usually at 2.15. So that's higher. That means that those prevalence are going to be higher. When defining like subclinical hypocalcemia, and this is like very recent research, there are like some questions about, because usually we define subclinical hypocalcemia as a decrease or low calcium concentration, so calcium concentration below 2 or 2.15 millimolar in blood within the 24 hours after calving. However, recent research showed that really more than like kind of like that decrease in calcium concentration, what really matters is how long those cows remain hypocalcemic. So there are like cows that would have like a drop in calcemia in the first 24 hours, but then they're able to recover right away, and those are actually the cows that are going to go and produce more milk and have like less diseases and everything. So these are actually like the cows that I would like in my herd. But again, so if we are just measuring at 24 hours, then we're not going to be able to differentiate those cows that are able to recover calcium concentrations from those that will maintain low calcium concentrations for about a week. So there's like a lot of discussion, and it's a lot of like studies going on right now trying to elucidate when we should actually like test for subclinical hypocalcemia. So stay tuned to the literature. talk about like clinical signs again, we have hypocalcemia. Those are really for more like, again, milk fever, since the clinical does not show clinical signs, and it affects both like demeanor, the behavior of the animal, and also some vital signs such as the heart rate and rectal temperature. And usually just kind of like we consider hypocalcemia in 3 different stages, but what is important to remember always, like the stage 1 is in cows particularly, as opposed to other species, is of very short duration and usually goes unnoticed, unfortunately, because as usual, as with most of things, the sooner that we can pick a disease and treat it, the better the outcome. But yeah, so as you can see, like the stage 1 signs are of short duration, and then they are like very mild signs. It's like, okay, cows might be more excited, they might be a little bit ataxic, they might have like some mild muscle fasciculations, they be like having like some ear twitching. So something that it might be difficult to notice, apart from the fact that they will just show those signs for like a short period of time before progressing to usually our stage 2, in which they are already recumbent. So the diagnosis of hypocalcemia, unlike for hyperketonemia, usually it's just based on the response to treatment, because obviously calcium affects muscle contraction, and that's a life-threatening condition. So we have no time to pull a blood sample and wait for the laboratory results for confirmation. And unlike the ketometers that we saw before, so far there are not really validated and cost-effective cow-side meters for calcium concentrations. Even though I'm like, okay, but we don't have really time to wait for the lab, I usually always advise to, before treating the cows for hypocalcemia, to just collect a blood sample pre-treatment, in case it is not hypocalcemia. So calcium is quite stable in the samples. So if we take the sample and then we treat it, if it doesn't recover, then we can always go back to a pre-treatment sample and see what was going on in that cow. And I mean, for calcium, it's like so easy that we really just need to take the sample, and we can, with either like a plain tube with no additives or in lithium heparin, and we can just leave it for like 14 days in the refrigerator. It's been like a paper published, it was like, last year or 2 years ago, that actually showed that calcium is stable up to 14 days, just for refrigeration in the proper tube. So no need to spin the tube and collect serum or anything. And with regards to kind of like trying to match the clinical picture of the animal with the blood concentration, it's very, very variable, but usually those cows that are recumbent, they are assumed to have usually or should have calcium concentrations in blood lower than 1.5 millimolars. But again, you always have like cows that when you test it, and they have, you just look at them and say, like, well, but if I look at your blood work, you should be down. And other cows that are down, that you look at the calcium levels and say, well, you should be up. So it's very variable among cows and cannot really be used to make decisions. So when it comes to treatment, like obviously the treatment to correct hypocalcemia is the provision of calcium. It's like, okay, if the cow has a deficit of calcium, we need to provide it with some calcium. So we need, and again, this is a life-threatening condition, so we need to act fast. So the questions really are, how much calcium should we give the cows, in which form, and how often? And we're going to go through those. So usually the calcium deficit in a cow that's suffering from milk fever is about 6 to 8 grams of calcium. If we think about like a bottle of half a liter of calcium borogluconate, that already has like 10.8 grams. So just with one bottle, we are already like covering the deficits of the cow. Now it's like, how do we administer it? Usually when we give it intravenously, the calcium concentrations in blood are going to peak in 15 minutes after the infusion. whereas subcutaneously it's going to take like 4 hours. So if a cow is recumbent and down and like her like vital functions are starting to be compromised because of the lack of calcium, usually she won't be able to wait for like 4 hours for those grams to get into the bloodstream, because the absorption is goes at a lower speed. However, when we give calcium IV, we need to be concerned, or at least be aware of the rebound effect. So we have a cow that has low calcium concentrations. So we give a lot of calcium like suddenly, so that creates an hypercalcemia. So we move from hypo to hypercalcemia. So that's going to decrease the secretion of parathyroid hormone. So it's going to affect like the regular homeostasis of the cow, and it's also going to increase the release of calcitonin. And calcitonin has like the opposite effect, which is to actually reduce calcium concentrations in blood. So what really happens is that, okay, we have like a cow that is hypocalcemic, starts here. So this like this gray area is the normal range. So we have like a cow that's hypocalcemic. We give her like our half a bottle of 23% calcium borogluconate, and that increases the calcium concentration really fast, to the point where we are getting close to the cardiac toxicity threshold for calcium. And because of that, then we are going to have like a calcitonin release that is going to just make and drop that concentration of calcium really fast. So even though, okay, we are correcting that calcemia, after 4 hours after the treatment, the cow is already hypocalcemic because of that rebound effect. So it's not that we increase the concentrations and then that just remains high. It's just like we increase it, then calcitonin gets into place and it's going to go down. So we really just have like 4 hours until the cow is hypocalcemic again. So we need to provide like with other like sources of calcium that would support her calcemia here. And yes, one way is what we saw before with like, okay, if the subcutaneous injection takes 4 hours, if we at the same time administer our IV, that's going to go really fast, and our subcutaneously, then we are going to have like some calcium coming up here that by the time that it gets to 4 hours is going to help maintain those calcium concentrations at above the normal range. Another good way of providing supplemental calcium is oral calcium. And I personally prefer oral over subcutaneously after the first IV injection. And it can be either done with like these like oral boluses of calcium or as a drench. It's important to know where is the source, what is the source of calcium, because their absorption in the gastrointestinal tract is going to be different. So the most effective, or the one that has like the better absorption, is calcium chloride, which is like about 95%. But when we start going down, we are giving like calcium carbonate, that is only like 50%. So that means that we need to actually give twice as much calcium orally as the cow actually needs. Other things to consider is that calcium propionate, it's good, has a good absorption, but the propionate component might be a little bit like problematic, because again, propionate is a gluconeogenic substrate, and we are fresh cows, particularly the time when it happens, like within the first 24 hours after calving, which is when we usually see milk fever, cows are usually already hyperglycemic because of all the stress of calving, etc. And there are like, again, not much evidence for that, but there's like some linkages between hyperglycemia and disease risk at that time. So potentially giving gluconeogenic precursors to one-day milk cows is not the best option. And again, always check the composition, because other salts of calcium, such as carbonate, oxide, or hydroxide, are really regarded as insoluble. So giving that and giving nothing is probably about the same. However, with the boluses, obviously, it's always remember to either train the staff doing it and be careful when doing it, because we always like problems with like what is called like an oral gun induced trauma, in which we have like the boluses that goes where it shouldn't have been, and as you can see in this picture, sometimes then it needs to be like removed surgically. So really what we are trying to do, again, going back to like this lays, like these things. So usually what I do with like the oral calcium is just, okay, I give my IV bolus, and when the cow recovers their swallowing reflex and it's able to swallow, then I give a calcium bolus. So that, and usually again just give one at 8 hours and another one 12 hours later, so that you have like this spike in calcium concentrations that supports the cow until it's able to regulate her own calcium. Usually with 1 or 2 boluses, it's usually okay. So again, like supplementation of calcium, again, oral versus subcute, things to consider that unlike the oral, the subcute dose can also potentially produce a rebound effect. So it's also always like that risk that if we provide calcium subcutaneously, we can also like then produce that decrease in calcemia. Subcutaneous absorption requires adequate peripheral perfusion, which is not usually what happens in mid-fever cows, because of the fact that they are laying down and recumbent for longer period of times. They're usually dehydrated, so that might delay the absorption of calcium. The calcium solutions are irritating when injected, so they can cause tissue necrosis, and oral supplements usually sustain calcium concentrations for longer. So, as I mentioned before, the boluses or oral supplements, usually because their absorption is like more continuous, can sustain calcium blood concentrations for about 12 hours, whereas subcutaneously it's only for 6 hours, which means that if we need to be like resupplementing with an oral administration, we need to supplement every 12 hours, whereas on with a subcutaneous one, we'll need to be like resupplementing every 6. Another interesting question is like, okay, particularly when giving calcium IV, should we give just plain calcium or calcium borogluconate, or should we do like these kind of like combinations of like 4-in-1 or like CMPK, in which there are like solutions that in addition to calcium, they also have like magnesium, glucose, and phosphorus usually. As mentioned before, that added glucose might be detrimental. Like the same thing with like giving glucose to cows that are already hyperglycemic, plus the fact that, as we mentioned for hyperketonemia, if we increase the urinary excretion of that unneeded needed glucose, then we can also excrete phosphorus, which is needed to regulate calcium homeostasis. And some of these kind of like combined products might not have sufficient calcium to meet the deficit of the cow. And really, if the cow only needs calcium, it's probably better just to give her calcium and not something else, unless there is evidence that there are like other problems contained. So it's good that it contains magnesium and phosphate, but those can also be administered orally, and particularly the phosphate of most of these like solutions is phosphite. Like the source of phosphate is really like a phosphite salt, which is pretty much useless in ruminants. So really the phosphorus in those solutions is like it was not there. So it's really good that they have magnesium because of everything that we saw before about like the role of magnesium in regulating calcium, but that can also be given orally if needed. So when we talk about like prevention, again here we obviously the key features of prevention is, as I mentioned before, trying to make the cows start mobilizing calcium before calving. So by the time that the demands for calcium increase during colostrogenesis and the onset of lactation, the cows are already like ready to mobilize calcium. So there are like two main strategies for that. One is like the use of a negative DCAD, or the dietary cation anion difference of the diet, in which what we are trying to do is to create a slightly metabolic acidotic status in the cows, so that in response to that metabolic acidosis, the cows need to mobilize phosphate from the bones, and as a consequence of that mobilization of phosphate from the bones, they also mobilize calcium. But so what it does is really activate all those mechanisms for like bone resorption that would otherwise take weeks to that. So our target usually on the dietary cation anion difference is something like between -10 and -15 microequivalents per 100 grams of dry matter for about 2 to 3 weeks before calving. So usually we move the cows for like counting for like 3 weeks, and usually some of them will calve sooner, but those cows would at least have been exposed to a negative DCAD diet for at least 2 weeks. When we are using like a negative DCAD diet, it's important that we should provide an adequate amount of calcium in the diet, because we are making the cows mobilize and also excrete in their urine a lot of calcium. So if we do not provide calcium in the diet, we can actually create hypocalcemia in their diets. However, problems like dealing with negative DCAD is particularly potassium. So controlling and achieving like a negative DCAD is challenging when the concentrations of potassium are higher than 1.4% of dry matter, because we will need to, usually we achieve that negative DCAD by supplementing the diet with anion salts such as calcium chloride or magnesium chloride or magnesium sulfate. So if we have this concentration of potassium, then we will need to add so many anion salts that that's going to decrease the palatability of the diet, and therefore the cows are not going to eat it. So then we will not only have the problem with hypocalcemia, but also the problem of like cows are not eating, so they are going to start mobilizing fat. So we are going to also have hyperketonemia. And it's also it's like even like harder when the concentration of potassium are higher than 1%, because at that level, the potassium also interferes with magnesium absorption that we know is essential for calcium metabolism. And these kind of particular problems with potassium are really characteristics of pasture-based systems. So really, when I was like working in Australia, really in trying to formulate and correct diets, getting to a negative DCAD was impossible. No matter how we tried, it was how close to zero it can be in the positive side of things, because getting to negative, it was almost impossible. The amount of potassium that was in the forages and everything, we will need to supplement so many like anion salts that the cows wouldn't go into it. Another strategy that is like more recent is like the use of like calcium binders or like zeolite. This still is like the same principle of trying to mobilize the calcium in the cows, but it's a different mechanism. And since it's like a more recent product, there is not as much evidence as for the DCAD, although like the evidence that there is available, it seems to be very positive. So how this acts is it will just bind the calcium in the diet. So what we are trying to do is kind of like still create like an hypocalcemic or slightly hypocalcemic status in the cows, in which we are like the calcium that is in the diet gets bind to this product, so it's not available for the cow to absorb. So the cow doesn't have sufficient calcium, so they need to start mobilizing that. And by doing that in the few weeks prior to calving, then we are getting the cow ready to go. A benefit of this strategy is that it does not affect the palatability of the diet. That was like the issue that we have with the anion salts that we needed for that negative DCAD. And that really, I mean, I had like seen like data from like a couple of farms that they just moved from like the DCAD diet to calcium binders as a strategy to control or prevent milk fever. And like how those dry matter intakes in the close-up trends increase, it was just like very surprising. So it really, for me, just raises the question of like, well, so is it this, then are we seeing really those effects just because of the decrease in calcium absorption, or how is also like that increase in dry matter intake and making like the cows eat more and have like a better rumen feel and everything, preparing them better for lactation, also contributed. Another potential issue that is still being explored on what impact it might have is that those binders are not specific for calcium, so they really bind to most of the cations in the diet. So yeah, it will also bind to phosphorus and potassium. And while potassium might be good, phosphorus is actually needed. And some of the initial research did show that when feeding calcium binders, the blood concentration of phosphorus decreased. So we still don't know what implications that might have. But again, when feeding it, if anything, is like a decrease in disease incidence, what was seen, not really any problems. Is more about like what implications that might have in the homeostasis of the animals. Okay, and with that, we're going to move to our third and last disease, which is hypomagnesemia or grass tetany or grass staggers. Those are like the main names that we see. And a feature of this disease that I'm just going to start right away up front with is that the evidence in support of like treatment, diagnosis, and everything for hypomagnesemia, like the strength of the evidence is for this disease is way lower than what we could find for like ketosis and hypocalcemia. Probably because with current like intensive dairy farm management is less of a problem than what it used to be. And it's primarily, one of the reasons is that, as we saw before, magnesium is essential for calcium homeostasis. And kind of like the threshold of the concentration of magnesium in cows that would cause problems with calcium homeostasis, it's higher than what is needed for cause the cows to go like recumbent and show clinical signs of hypomagnesemia. So usually, if the cows are experiencing a problem with magnesium concentrations and their blood concentrations start to decrease, we are going to usually at the hair level see first issues with calcium homeostasis or hypocalcemia before we are able to see hypomagnesemia. So in a well-managed herd, if we are able to pick those hypocalcemia problems, and as part of our treatment, we are also going to provide magnesium, we are not going. That's one of the potential explanations why we don't see as much hypomagnesemia as we see of the other diseases. So again, as you can see here, like compared to calcium, like really magnesium is not, I mean, it's still like primarily stored in the bone, but there's like another, like at least like other fluids that have sufficient magnesium. So it's not everything in the bone as it was for calcium. But so yeah, what is important? Like magnesium is essential for like several key features such as nerve conduction, muscle function, bone formation, and everything. One of the interesting and key features of magnesium is that, okay, magnesium is stored in the bone primarily, as we see, but there is no mechanism to actually mobilize magnesium from the bone of the animals when the magnesium stores or demands increase. So there is no way for a cow to start mobilizing magnesium in response to decreasing the magnesium concentrations in blood. That means that all our kind of like blood concentrations or plasma magnesium concentrations are momentarily just based through the diet and the magnesium absorption. Because the bone resorption happens in response to calcium status, not magnesium. So yes, if we have hypocalcemia, we are going to resorb bone, and as part of that, some magnesium will get released. But if the problem is just magnesium, there is not going to happen any like bone resorption. So again, magnesium gets absorbed primarily in like the reticular rumen, so it's not like calcium that gets absorbed a little bit in the rumen, but primarily in the duodenum. And we have like two main mechanisms for absorption of magnesium that we need to cover because they kind of like affect how we are going to treat and prevent this disease. So the one is the active absorption. That means that happens through a transporter. So we have like magnesium in the interior of the reticular rumen that it gets through the transporter and gets absorbed into the bloodstream. However, this transporter kind of like when we have like high concentrations of potassium, that this gets blocked. There is another way, which is a passive absorption, in which like does not require a transporter, and the magnesium just kind of like diffuses through the ruminal epithelium. However, for this to happen, we need to have, or the cow needs to have, high concentration of soluble magnesium in the ruminal fluid. So it's like when the concentration of magnesium is high enough in the rumen, then it will passively diffuse to the ruminal epithelium, bypassing that blockage of calcium. So if we provide sufficient magnesium, we don't need to be concerned about the potassium interfering with the absorption. And that's usually like believed to happen at dietary levels of 0.35% of dry matter. Obviously, when this is just like a list of different factors that would affect the transport or the absorption of magnesium in the diet, and like the main one is like factors that would affect either the solubility and the concentration of magnesium in the diet, and then like again the other one, which is like the transport part. So we have like the rumen pH is going to affect magnesium solubility, so that when the pH is lower, the solubility is higher. So cows that are just on pasture that usually have like a higher pH, then would have like a lower magnesium solubility. As we saw again for like calcium before, like the source of magnesium is also going to affect its solubility. And yeah, so magnesium oxide is probably the most widely used in ruminant diets, but to be soluble in the rumen, we have like several factors that affect it. One is like the level of groundedness, so it needs to be like grounded to less than 200 micrometers. And usually sometimes like when creating magnesium oxide, that needs to be like heated, and sometimes we have like when the magnesium content in magnesium oxide is more than 56%, that means that it has been like overheated and then it's not soluble. And there are like other sources of magnesium, such as chloride or sulfate, that yes, they are easy to absorb, but they are not really palatable. So unless you drench, they're good for a drench, but not very good to top up the diet or even the water. Obviously, like the presence of some organic compounds can just make, like if you have like organic acids in the rumen, that can form like insoluble salts in the rumen, so that magnesium is not able to be absorbed. And when we think about like, magnesium transport, obviously like the sodium to potassium ratio that we just cover and the dietary magnesium concentrations that we need to have like magnesium concentrations in the rumen sufficiently high for that passive diffusion to happen. And obviously then it's just like the availability of lush, high moisture pastures, and that just has to do with like the amount of time that the ruminal contents stay in the rumen. So if it increases kind of like passage time, then there's less time for the magnesium or anything else to be absorbed in the rumen. And there is not really much magnesium absorption happening later on or down the GIT tract. So if we increase the passage time, then there is no sufficient time for the magnesium to get absorbed. Epidemiology of the disease, again, like more common in beef than in dairy, partly because of what I already explained about like how dairy are managed in terms of population and the fact of like the calcium. And also because beef are usually more in pastures right now than dairy. And it's usually associated with grazing last pastures that are high in nitrogen and potassium and low in sodium and magnesium. Again, if you go back to what we just discussing about the absorption of magnesium in the ruminant and everything, this is kind of like everything makes sense. And usually it's more often during the fall and the spring, just because that's when the pastures are growing at a faster speed, and that's when we are going to have, like, again, low concentrations of magnesium and sodium and higher concentrations of nitrogen and potassium in those pastures. It's usually observed in lactating animals, or more commonly observing at lactating animals than in non-lactating ones, and it has to do just primarily with the demands for magnesium, since to produce a liter of milk, we need 0.15 grams of milk. So if we think about a dairy cow that just calf and is producing about like 30 liters of milk per day, that means that she needs 5 grams of magnesium per day. If we look at everything that is available in the extracellular compartment, like the extracellular fluid in blood, like the requirements to produce 1 day's worth of milk are higher than all the magnesium that is available in kind of like the extracellular space. Clinical signs of hypermagnesemia, again, we kind of like can classify it between like more moderate and severe. And again, these do correlate a little bit with the serum concentration of magnesium. So usually this is meant to be like lower than. So when serum magnesium is low, is between like 0.8 and 1.1 milligrams per deciliter, we will have like reduced feed. Cows will show like reduced feed intake, reduced milk production, reduced milk fat. A characteristic of like this disease is nervousness. So cows would get particularly excitable. They will show like rapid movements and would show like an exaggerated response to stimulation. And again, it like these at this level of magnesium concentrations, this can be like a chronic problem that goes unnoticed, because those clinical signs, it's not like a complete, it's not that cows will completely stop to eat or will completely stop to produce milk. It's just like a reduction. So it might be like a chronic unnoticed problem, but apart from like those losses, we have to take into account that it's going to predispose cows to milk fever. And then like the more severe part, when actually like concentrations of magnesium go below 1.1, is that then it starts to talk about like twitching of muscles, irritability, and aggressiveness. This is like sometimes like really scary, I can tell. Like you will be like chasing down by the cows and everything. I have like some videos of that I'm not going to show just because they're a little bit embarrassing. But the clinical signs can be like really subtle, and sometimes to actually, when you are trying to make a diagnosis, you might need to actually stimulate the cow to kind of like stimulate that response. And as the disease progresses, or as the cows remain for a longer period of time with low concentrations of magnesium, then we are starting to see like tetanic spasms, clonic convulsions, and frothy salivation in the animals. An interesting thing of like the clinical signs is that after like they have like that tetanic episode, cows might be able to just, they can't like go down and have like that. It seems that they're having like a seizure, and then they're just able to race after that. But those kind of like episodes might continue several times if we do not correct that magnesium deficit. And again, because of all the implications that magnesium have, if that's not corrected, cows can die. have here, like, again, like the clinical size compared to like of hypomagnesemia. That's really what we like looking at. An interesting feature that is sometimes it has like diagnostic value is that like the heart rate usually increases, and so do the sounds. So they have like pounding sounds of the heart, and usually like these would show an increase in rectal temperature, and that's usually because of all that muscle activity that goes associated with the tetanic episodes and convulsions. Again, the diagnosis is similar to hypocalcemia. Most of the times, cows need treatment right away. We have no way to make a diagnosis based on blood work if they're already showing like clinical signs. So we just base our diagnosis on how well do they respond to treatment. Again, as commented before, always recommended to take a pre-treatment sample. So when we have like magnesium concentrations lower than 1.8, that's in blood, that suggests poor magnesium absorption or poor availability. So something is going on with the magnesium. That it's important to note, though, that magnesium concentrations in blood taken right after or measured right after a tetanic episode might be falsely elevated. Because of all that muscle activity, there's like leakage of magnesium from the myocytes into the blood. So ideally, you should, if possible, like most of the times, a blood sample doesn't get collected, but if it needs to, taking it right after a tetanic episode is not a good idea. It's also not uncommon for the diagnosis needs to be made post-mortem because it happens overnight or everything that hasn't been picked up. And what it happens is that you have a cow that died or several cows that died with signs of like convulsions around their bodies. And you are asked to make a diagnosis and try to see what the problem is or what the cause of the deaths were. So when we're doing it post-mortem, an important thing is that, okay, magnesium in this CSF would remain low for up to 12 hours after that. So we can measure magnesium in the cerebrospinal fluid. Also, the vitreous humor magnesium concentration is also reliable for about like 24 to 48 hours, but that's dependent on the environmental temperature. So it needs at warmer temperatures, then it does not become that reliable. Important feature is that is like the vitreous humor, the aqueous humor. It's not of diagnostic ability, so you need to make sure that if you're collecting it, you're collecting it from behind the lens. And like the problem with magnesium, as you can see, that it's always not like a cow's problem. It's usually a problem with the availability of magnesium or the absorption of magnesium. So really, seen one case of hypomagnesemia, that's usually an indication that a problem at the herd level is happening. So you should also consider checking other cows in the herd and see whether that's. So sometimes the diagnosis can be made not on the cow that it's affected, if it just happened to have a tetanic episode, or in the cows that are dead, but in other cows that are still in the herd. And if they have low plasma concentration of magnesium, that is suggestive that hypomagnesemia is a problem at that farm, because really it's a herd level problem, even if it just shows in one cow. How do we treat hypomagnesemia? Again, as I mentioned before, there's like way fewer studies than for hyperketonemia, milk fever, about like optimal treatment regimes for hypomagnesemia. But really what is important is to, okay, first provide IV magnesium really fast to normalize magnesium concentrations. Usually a cow would need 1.5 to 2.25 grams of magnesium. And usually this is achieved by if we just give like half a bottle of calcium borogluconate combined with magnesium, either or with a magnesium salt, hypophosphite chloride or borogluconate. That will be like between like our 1.5 and 4 grams of magnesium. The administration of solutions that contain only magnesium IV for IV administration is not recommended because there is an increase when we are administering just magnesium. There's a high risk of respiratory and cardiac failure. And that risk is reduced when we also provide calcium, because there's then it's some competition between the calcium and the magnesium for binding sites. So that's why we usually combine and give calcium and magnesium. And also, as I mentioned before, because of what we know that of the role of magnesium in the diet, it's actually beneficial. In addition, because, if the cows were hypomagnesemic, then most likely they also had some issues with calcemia. So they will also benefit from administration of calcium. Important thing to consider with regards time to recovery, etc., is that what the clinical signs that we are seeing on hypomagnesemic case are due to low concentrations of magnesium in the CSF. And once we correct the magnesium concentrations in blood, then it will take up to 1 hour for the magnesium concentrations in the CSF to normalize, because the blood-brain barrier slows the diffusion of magnesium. So we need to allow that time for the magnesium in the CSF to be normalized to expect recovery of the animals. And during that time, it's important not to stimulate the animal, because as we saw before, if you get it stimulated, then they can have another tetanic episode. So just let the cows stay for about 1 hour and then reassess. Sometimes, or most of the times, you will need to further treatment after 12 hours, because again, the same issues that we saw with calcium, just with one administration, we are not going to normalize the magnesium concentrations, and it's going to take some time for the animal to be able to regulate herself. But that supplement administration of magnesium can happen either subcutaneously or oral, which is personally my preferred route, or also administration of rectal enemas. So yes, and that's particularly useful to use by the owners or the farmers, because even if it was not hypomagnesemia, it's not going to make or kill the animal. So if you have a cow of suspected hypomagnesemia and you cannot provide immediate veterinary attention, then you can have trained your farmers to provide an enema with a salt of magnesium sulfate, because this is it's a safe alternative, and it will help not as fast as IV, but it will help absorb magnesium. One question that always comes up when treating cows with hypomagnesemia is that cows are aggressive if they are on the severe stage. So it's getting close to them enough to actually insert a needle to put an IV catheter, it's challenging. And so sometimes people would rather just sedate the animal first, so that they don't get injured. And usually that use sedatives that can be used intramuscularly, such as xylazine. However, the problem is that cows are already their perfusion and vascular function is already compromised. So if we administer sedatives, particularly if we give them IV, that can lead to sudden hypotension and death. Obviously, your own safety comes first. So if you do need to sedate an animal, just use as light sedation given IM, and try not to give IV sedatives, because then you can kill the animal before you can actually correct the problem. For the prevention of the disease, again, as I mentioned before, consider this a hair problem. So if you have a case of hypomagnesemia, again, this is such a nutrient-derived disease that a case is indicative of insufficient absorption or availability of magnesium for the cows. So you need to check the nutrition, and you need to check the other animals, and the other animals might need immediate supplementation. How much magnesium is needed as supplement? This here are some numbers. So usually this is per day. So usually you should get between 10 and 15 grams of magnesium per pregnant cow. Then when lactating, the demands kind of like increase, and obviously increase more for like lactating dairy cows that will have like 30 grams per day than in a beef cow that produces less milk, and it's like 20 grams. Obviously, it's more practical as a dietary supplement than if you have to like drench every single cow. Although we need to realize that really it's not possible to ensure intake for all animals. So you need to kind of like wait how severe the problem is, and it might be that the first time around cows need to be drenched, and then you can just go around with dietary supplement. So one of the alternative, or like one of the ways of doing that is just to dust pasture, if there's like a pasture-based system such as in beef cows, with magnesium oxide. Again, remember that magnesium oxide is only 50% available, so we need to provide 20 grams per cow of magnesium per lactating beef cow. Then that means that we need to provide 40 grams of magnesium oxide per lactating cow. So we need to provide twice as much magnesium oxide as the magnesium needs are. Another way of doing that is like the supplementation of the water troughs. And yes, that's about like providing 5 to 10 kilograms of magnesium either of a magnesium salt per 2,000 liters of water. And with that, we just covered the prevention, and we just addressed the 3 diseases that I was going to talk about before. So hopefully now we have some questions and we can have a discussion.
Hello. Thank you, Doctor. Hello, Doctor. Thank you, Dr. Angel. That's for the neat lecture. Please give us 2 minutes time to gather the questions. Meanwhile, Dr. Santosh, can you put a filler?
Yes, I will.
2 minutes, Dr. Angel, please.
Yep, sounds perfect. No problem. I'll get some water.
Thank you, Dr. Santosh. Dr. Angel?
Yes.
Yeah, we have got a little number of questions. After we had 32 questions, of which majority are there in your lecture. So
Okay.
4 left unanswered, so I am putting on to you.
Okay.
Yeah. So what about the oral propylene glycol? What is the availability in your place? Is it in a liquid form?
Yes.
Yeah. What
So
is the
Go ahead.
company name? If it is possible, you can pronounce.
Oh, the company name. There are like many. Here is.
Okay. Okay.
So yeah, I mean we can, but yeah, so it comes in an oral form. It's kind of like rather dense liquid. We either regularly just use kind of like those kind of like guns that like that as in the picture that I showed that it already comes with like 300 milliliters. So that we just put in the mouth of the cows. The cows don't really like it that much, or as part of our like drench, where we actually like tube the cows and we just put the propylene glycol if we are giving something else.
Okay, thank you so much. While dealing with the different preparations of calcium chloride, calcium sulfate, calcium carbonate, so do you think there is any thing related to palatability or the animal readily accepts?
So sorry, I didn't hear the first half of the question. Can you repeat that, please?
You are telling about calcium chloride, calcium sulfate, carbonate. So of which 95% is advisable because calcium chloride does 95%. But we want to know among the three, does the palatability affects?
Oh, I get. Yes, I think that I understand. So the question is like whether the absorption capacity is related to the palatability of the salts.
Yes.
Is that yes? So they are not. So yeah, so they might be like the most like the ones that show better absorption, but might not be the more palatable ones. But you also, because of they are like the ones that have like better absorption, we do need to provide less of it. So you always need to provide. You would need to provide twice as much like calcium oxide than calcium chloride to provide. Does that make sense?
Yeah. Thank you. Now, collection of the fluid, vitreous humor, does the time of collection affects the concentration, what we are supposed to do, the estimation?
Yes, I mean, it's really challenging to know. Again, like with like the vitreous humor, you know that at least it's like 24 hours. So you after the animal is dead. So if you know that it was at the same time that you're collecting the sample, the animal was alive the previous day, then it's something, if you don't really know when the death happened, probably there's no point on taking the sample. But if you kind of have like an estimate of like, oh, it just happened overnight, or yeah, last day the cow was fine, then it's like, if it's like for 1 to 2 days, it's stable. But after that, it degrades. So after like 48 hours is not considered to have diagnostic ability because it's going to be low, whether it was low to start with when the cow died or not.
So the cutoff is 24 hours?
24 to 48, yes.
Okay, thank you. Regarding the supplementation, you were telling about rectal enema. Can you please tell about the percentage of solution or the quantity to be used?
Yeah, so usually that's about, so that's a really good question. So it shouldn't be very concentrated. So usually it's between like 30 to 40%. I usually use magnesium sulfate. If you go higher than that, then it can cause issues with like the irritation of the mucosa. So really just go for like 30 grams, 40 grams per 100 mLs of water. And I usually just put like 2 to 3 liters of that.
Yeah, thank you so much.
Okay, so like the purpose of that really is to support calcium magnesium concentrations up until kind of like the veterinarian can get there, if it's like preventative or if it's after the treatment, to continue supporting calcium concentration. So it's not really the treatment. The cow will still need to be treated with IV magnesium later on. It's more of kind of like if I cannot get there in time, let's just start doing this. And once I've been treated, once the cow has been treated, to support the magnesium concentration. So it's not as an alternative to treatment.
Thank you so much. Thank you, Dr. Angel ABUELO. I personally thank you for readily accepting our invitation on behalf of Tamil Nadu Veterinary Animal Sciences University. And this is really very good, informative lecture. We've enjoyed your lecture. Now, on behalf of organizing committee, may I request our respected and beloved Director of Clinics, Dr. S. Balasubramaniam, for his concluding remarks on the webinar.
Thank you very much.
Greetings from the Directorate of Clinics, Tamil Nadu Veterinary and Animal Sciences University, India. Indeed, I am very happy to be here to give the concluding remarks of this 2 days TANUVAS Global Large Animal Sciences Webinar Series 2 2021. This is being organized by the Department of Clinics, Veterinary College and Research Institute, Namakkal, which is under the control of Directorate of Clinics, TANUVAS. So before I go to the concluding part, so it reminds me of the message which I got through WhatsApp regarding the corona pandemic situation. So this message is like coronavirus has submitted its annual performance self-appraisal for 2020 for its promotion. So there are 15 points given by coronavirus. So the first and foremost point is it is responsible for global digital transformation and fast tracking. Other than the other aspects, like it made us learn so many things, the values of life, values of your friends, values of your relatives, and it goes on like that. But the first and foremost, as I said, it is the responsible for global digital transformation and fast tracking. So this is the one which has forced or pushed the entire world to shift from classroom teaching to virtual learning. So in that way, even we are not an exception. So we had organized from the last August, we had 7 global webinars, and we have invited several people, well-renowned personalities in their respective area of specialization. In that way, this particular webinar series on 7th and 8th is getting concluded today. We had 3 international speakers. Yesterday, we had Dr. Elizabeth Kerr from USA. She had delivered a lecture on critical care management of foals. And today, in the afternoon, as per the Indian Standard Time, we had Dr. Brandon Fraser from Australia, who presented a very elaborate lecture. It went on for over 2 hours with an interval of maybe 10 minutes break. And he presented on the medical management of diseases of small ruminants. And now finally, we had a very interesting, illustrative, self-explanatory lecture on production diseases in cattle by you. That is Dr. Angel ABUELO from USA. So just to endorse, you may be wondering why we had very little questions being addressed in your lecture. So for that, the answer is that we had 1,100 odd people who have registered, and out of which 1,007 were online. So that itself is a big, a landmark. And out of which 132 participants from 18 countries other than India. So, as I told you earlier, that your lecture was self-explanatory because you made it very clear, and it like clinical science, very clear clinical science, how to make out those clinical science, treatment, straightforward treatment, and prevention, again straightforward. So I think the practitioners, students, it will serve as a ready reckoner because this is going to go as a recorded version. And I think we will send you the whole recorded version to you too. So any point of time, people can just refer. And I think it will be very useful for the students and the practicing veterinarians. So it is my privilege to propose this concluding remarks. And I would like to thank you very much for having readily accepted our invitation and for having joined us in this global webinar series. And I hope in the months to come, I think we need to go with this type of virtual learning, and probably we may again get back to you on some other interesting topic. Thank you very much. Have a nice day.
Thank you, sir, for the neat, brief comment on the webinar. Thank you very much. May I call upon Dr. Sandil Kumar, Assistant Professor, Department of Clinics, for proposing vote of thanks.
Proposing vote of thanks in this Grand Gala Technical Knowledge Sharing Program, TANUVAS Global Large Animal Sciences Webinar Series 2 2021. At the outset, I wholeheartedly thank the Chief Patron of this program and Honorable Vice Chancellor of TANUVAS, Dr. C. Balachandran, for the permission and support to conduct this program. I sincerely submit our thanks to the patron of this program and respected Registrar TANUVAS, Dr. P. Tensing Jnanaraj, for according permission to conduct this webinar series. Further, I wholeheartedly extend our thanks to the convener and chairman of this technical webinar series and director of clinics TANUVAS, Dr. S. Balasubramaniam, for the dynamic support, continuous effort, and mobilizing resource persons from across the globe due to his wider international contacts for the successful conduct of this webinar series program. Further, I sincerely thank the resource persons and international speakers, Dr. Elizabeth Carr and Dr. Angel ABUELO, College of Veterinary Medicine, Michigan State University, USA, and Dr. Brandon Fraser, Large Animal Clinician, University of Queensland, Australia, for their exhaustive, informative, and elaborative technical knowledge through their lectures. I sincerely thank the organizing secretary and professor head clinics VCRI Namakkal for effectively organizing this program. I am immensely thankful to Dr. G. Vijay Kumar, co-organizing secretary and professor head VUPH Chennai, for effectively and dynamically coordinating this webinar series. Further, I thank Dr. P. Sankar, coordinating secretary, other moderators, the technical coordinators, the members of coordinating committee for their sincere efforts in successful conduct of this program. I sincerely thank Mr. P. Karunanidhi, Vice President, Alembic Pharma, and Dr. Santosh Shinde, AG Marketing, Alembic Pharma, for their technological and technical support. I submit my sincere thanks to the deans and faculties of constituent colleges for their coordination and contribution for this conduct of this webinar. I thank the professor heads of Department of Animal Husbandry Economics and Animal Husbandry Statistics and Computer Application for deputing faculties for this technical coordination. Last but not the least, I thank all the participants for eagerly and enthusiastically participating in this technical webinar series. Thank you, one and all. Thank you very much.
Thank you, Dr. Senthil. Thank
you,
you, Dr. Angel ABUELO for joining us. And then we conclude the webinar. Thank you.